Good afternoon to the chairman, esteemed professor, and the dear college. My name is Trần Phúc from Huế University of Medical and Pharmacy Universities. Today, I will happy to present the topics of assessment of 10-year cardiovascular risk among patients with type 2 diabetes in Vietnam. And my presentation today divided into 5 parts. First of all, I want you to know that cardiovascular disease or CVDs continue to be the leading cause of death worldwide. And Asia is one of the regions most heavily affected by cardiovascular disease. But CVD does not travel in part alone because over 70% of cardiovascular disease worldwide is caused by modifiable risk factors. Here you can see that cardiovascular disease has many risk factors such as diabetes, tobacco, or many others. According to the data, diabetes is the second leading cause of CVDs after hypertension. And here's the 3 common mechanisms why diabetes promotes CVDs, like insulin resistance, chronic inflammation, and dyslipidemia. According to the data of IDF 2025, there are 589 million people worldwide living with diabetes. And Vietnam is projected to be the region with 1 to 10 million people living with diabetes. Both trends are rising together, making the cardiovascular burdens of diabetes patient a major challenge. CVD is a leading cause of death and disability in people with type 2 diabetes, and yes, many people with type 2 diabetes are unaware of their risk. And that's why the burdens of both conditions is enormous. In other countries, many studies have evaluated cardiovascular risk in patients with diabetes, thereby providing data to support the development of appropriate plans and strategies of community intervention. However, data in Vietnam remain unclear. So, we conducted an epidemiology studies of assessment of 10-year cardiovascular risk among patients with type 2 diabetes mellitus in Vietnam to assess the prevalence and status of comorbid condition in Vietnam patients with diabetes and to evaluate their cardiovascular risk. Our study design is multi-center cross-sectional design conducted across 5 regions in Vietnam, and the time is between January to August in 2024. Our sample size estimation and sampling technique is patient age between 40 to 69 years, diagnosis with type 2 diabetes according to 2023 ADA guidelines. And our exclusion criteria is patient who decline to participate, other form of diabetes, patient with history of CVDs, patient currently receive anticoagulant therapies, and pregnant and breastfeeding women. Our CV risk prediction model is Prevent's online calculators. And here's the parameter we use for CV risk prediction model. And the final result is the numbers estimate of 10 years risk of CVD. We use Prism and RStudio to analyze this data. Next, we move to the results and discussion. First of all is the baseline characteristic of the study cohort. The number of male smokers is many times higher than that for females. The median age of females is higher than that for male. Females have lower blood pressure compared to males. Blood lipid levels are higher in females compared to males. In contrast, males have higher eGFR levels. The chart highlights strikingly high prevalence of dyslipidemia, affecting nearly 9 out of 10 individuals. Hypertension is also prevalent in over 2/3 of participants. While overweight and obesity are slightly less common, they still affect more than half of the population. And despite the treatment, a significant proportion of patients with type 2 diabetes in Vietnam fall into mid-recommends targets of blood pressure, lipid levels, and glycemic control. And the pie chart shows that 2 of 3 patients living with diabetes fall into high and very high risk. And the cardiovascular risk is significantly higher between for male than compared to female patients. And the patient with poor glycemic control has a higher proportion of intermediate and high cardiovascular risk, whereas those with good glycemic control were more likely to be at low risk. Good blood pressure control was associated with high proportion of low-risk patients, whereas poor control was linked to markedly higher intermediate and high cardiovascular risk. And poor lipid control associated with higher intermediate and high cardiovascular risk, whereas good control show a greater proportion of patients at low risk. The majority of patients with good control on these factors were classified as low risk. However, only 3% of patients in study achieved good control of all three. And the core question we sought to answer that: does a long duration of diabetes increase cardiovascular risk regardless of the factors? According to our data, we found that multivariate analysis showed that risk factor control was independently associated with low cardiovascular risk regardless of age and duration of diabetes. Our study has some key strengths like large sample size, exactly is 1,444 patients from multiple healthcare centers nationwide, providing good population representativeness. But our studies still have some limitations, like laboratory tests were not synchronized, leading proportion variability in measurements, or cross-section design is underway to assess actual long-term cardiovascular outcome. So we have some conclusion. First of all is in Vietnam, the prevalence of good glycemic control was adequate management of cardiovascular risk factor in particularly low. The second is majority of patients in diabetes has at least an intermediate level of cardiovascular risk. And the final is good control of risk factors sustainable risk reduce cardiovascular risk regardless of age or duration of diabetes. I am so happy to present our topic today, and thank you for your time and attention.